Stop walking for a second. Right now, wherever you are, stop and look down at your feet. Now ask yourself something strange. When was the last time you actually thought about how to walk? You haven't. Not since you were maybe 18 months old. Walking is the one skill your brain decided decades ago it would never have to think about again. It became automatic, invisible, free. And then, somewhere after 70, for millions of people, that free, invisible gift starts to break. Not all at once. Not with a dramatic fall down the stairs. It breaks the way a hallway light flickers before it finally goes out. A little wobble here. A little drift to one side there. A sudden need to grab the counter for no reason you can explain. Here's the part nobody tells you. It is almost never your legs. Say that again in your head. It is almost never your legs. Your muscles might feel weaker, sure, but the reason you can't walk in a straight line anymore, the reason you drift, sway, or feel like the floor is doing something slightly different than what your eyes are telling you, has almost nothing to do with strength and almost everything to do with a three-way conversation happening inside your skull that most doctors spend 90 seconds discussing before reaching for a cane. Today we're prying that conversation wide open. We're going to walk through exactly why this happens, what's actually breaking down, and the real fix. The one that has almost nothing to do with what you've probably already been told. If you or someone you love has started drifting, stumbling, or feeling unsteady for no reason, do not look away from this video. This is the one. Your ability to walk in a straight line depends on three separate systems constantly arguing with each other 60 times a second. And your brain has to instantly referee the disagreement. System 1 is your vestibular system, a tiny set of fluid-filled canals in your inner ear that tell your brain which way is up, whether you're turning, and how fast you're moving through space. System 2 is your vision, your eyes feeding your brain a constant stream of information about the horizon, nearby objects, and your position relative to the ground. System 3 is proprioception, sensors in your joints, muscles, and the soles of your feet that tell your brain exactly where your body parts are in space, even with your eyes closed. When you were 25, these three systems agreed with each other almost perfectly, instantly, all day long. Your brain didn't have to work hard to referee them because they were rarely in conflict. After 70, something strange happens. Each of these three systems starts degrading, but not at the same rate and not in the same way for any two people. Your vestibular system loses hair cells in the inner ear. Your vision changes, sometimes from cataracts, sometimes from changes in depth perception. Sometimes from the eyes simply taking longer to refocus. Your proprioception weakens because nerve signals from your feet and joints slow down and become less precise. So now your brain isn't getting three systems whispering the same message. It's getting three systems shouting slightly different, slightly delayed, slightly distorted messages. And it has to guess which one to trust in real time while you're trying to cross a parking lot. That guessing game is what feels like wobbling. That's the drift. That's why you suddenly grab a wall for no obvious reason. Your brain isn't malfunctioning. It's doing triage on bad data. Picture this. You mentioned to a doctor that you've started drifting to the left when you walk down a hallway. They glance at you, nod, and say something like, "Well, that happens as we age." and move on to the next topic. That sentence, "that happens as we age," might be the single most damaging phrase in modern senior medicine, because it's true enough to sound reasonable and vague enough to excuse not investigating further. Yes, balance systems decline with age on average, but decline with age is not a diagnosis. It's a description of a symptom dressed up as an explanation. It's like a mechanic telling you, "Cars get older," when your steering wheel pulls to one side. Technically true, completely useless. The real question is never, "Why does this happen to people my age?" The real question is, which specific system in my specific body is sending bad signals? And can it be improved, corrected, or compensated for? Because here's what most people don't realize. A huge percentage of balance and gait problems in older adults are not the inevitable, untreatable decline that they appear to be. Many have an identifiable, addressable contributor. Inner ear crystal displacement, medication side effects, vitamin B12 deficiency affecting nerve signaling, vision changes that haven't been corrected, blood pressure dropping when standing up, weak hip stabilizer muscles that have quietly atrophied from years of sitting, peripheral neuropathy from undiagnosed or poorly controlled blood sugar issues. None of those are simply getting older. All of those are specific, often correctable contributors that get lumped under one lazy phrase. If you've been told your walking problem is just age, and no one has actually walked you through which of your 3 balance systems is struggling and why, you have not gotten a real answer yet. You've gotten a shrug with a medical degree attached to it. There are literal tiny crystals inside your inner ear, and when they come loose, they can make the entire room feel like it's spinning or tilting when you move your head a certain way. This condition is called BPPV, benign paroxysmal positional vertigo. Inside your inner ear, there are structures containing tiny calcium carbonate crystals called otoconia. They're supposed to stay in one place, helping detect head movement. But as we age, they can become dislodged and drift into the wrong canal. When that happens, certain head movements, rolling over in bed, looking up at a shelf, tilting your head back at the hair salon, send false signals to your brain that you're spinning, even though you're not moving at all. This is shockingly common in older adults, and it's frequently misdiagnosed or simply never diagnosed at all, because the spinning sensation is brief, and people often don't connect it to their day-to-day unsteadiness. The wild part is that this is one of the most fixable causes of dizziness and imbalance in older adults. There's a series of specific head and body movements called the Epley maneuver, performed by a trained physical therapist or doctor that can physically reposition those displaced crystals back to where they belong. Many people experience dramatic improvement after just 1 or 2 sessions. If your unsteadiness comes with any sensation of spinning, especially when you change position, rolling over, looking up, bending down, ask specifically about BPPV and ask for what's called a Dix-Hallpike test. This is a simple, quick test that can identify the problem in minutes, and it is wildly underused given how treatable the condition is. Open your medicine cabinet right now, mentally, if you're watching this and not near it, and consider this uncomfortable possibility. 1 or more of the pills you take every single day might be the actual reason you're unsteady on your feet. This is one of the most underappreciated contributors to balance problems in older adults, and it's almost never the first thing addressed because each individual medication seems harmless on its own. Blood pressure medications can cause a drop in blood pressure when you stand up, called orthostatic hypotension, leaving you briefly lightheaded and unsteady, exactly during the moment you're most vulnerable, transitioning from sitting to standing. Certain sedatives and sleep aids linger in your system longer than intended, dulling reaction time and coordination well into the next day. Some antidepressants and anti-anxiety medications affect balance centers in the brain. Anticonvulsants, used for nerve pain or seizures, frequently list dizziness and gait disturbance as side effects. And here's the trap that catches almost everyone. When you're on multiple medications simultaneously, their combined effect on balance can be far greater than any one of them alone. Yet no single doctor prescribing each individual medication may be looking at the full combination. This is sometimes called polypharmacy risk, and it disproportionately affects older adults who on average take more prescription medications than any other age group. What should you actually do? Ask your doctor or pharmacist directly. Can you review every medication I'm on and tell me which ones, individually or in combination, are known to affect balance, coordination, or blood pressure when standing? Many pharmacies offer a full medication review specifically for this purpose, and it's worth requesting one at least once a year. Do not stop any medication on your own, but do insist on a real conversation about whether the combination you're on is contributing to your unsteadiness and whether safer alternatives exist. When was the last time you actually used your hip muscles on purpose? Not your quads, not your calves. Your hip stabilizers, specifically the gluteus medius, a muscle on the side of your hip that most people have never consciously engaged in their entire lives, because daily life almost never requires it directly. This muscle's job is deceptively important. Every time you take a step, it's responsible for keeping your pelvis level and stable on the leg that's planted on the ground. When this muscle is weak, which happens to almost everyone who sits for long periods of their daily life, which is most people in modern life, your pelvis drops slightly with every step on that side. Multiply that tiny drop by thousands of steps a day, and you get a gait that looks like an unmistakable side-to-side waddle or list, often described as drifting or veering. This is one of the most common, most overlooked, and most fixable contributors to unsteady walking in older adults, and it rarely gets addressed because it doesn't show up clearly unless someone is specifically looking for it, usually a physical therapist watching you walk from behind. The fix is almost insultingly simple. Targeted hip strengthening exercises, side leg raises, clamshells, standing hip abductions using a resistance band. These take minutes a day and done consistently over weeks can measurably improve gait stability, not by improving your balance system directly, but by giving your body the physical foundation that balance corrections depend on. Even perfect inner ear function can't compensate for hips too weak to hold you steady. If you've never had a physical therapist specifically evaluate your hip and core stability as it relates to your walking, that is a significant, fixable gap in understanding what's actually happening with your gait. Once you become afraid of falling, that fear itself starts to make you less stable, creating exactly the outcome you were afraid of in the first place. This has an actual name in medical literature: fear of falling, and it can develop into something called post-fall syndrome, even in people who haven't fallen yet, but have simply become afraid of falling after a close call or after watching it happen to someone else. Here's the mechanism. When you become afraid of falling, you unconsciously change how you walk. You take shorter, more cautious steps. You stiffen your joints instead of letting them move naturally. You hold your arms differently. You avoid certain movements, bending down, turning quickly, walking on uneven surfaces, that your body actually needs to practice regularly to stay capable of doing them safely. This altered, stiffened, restricted way of moving is ironically less stable than a confident, naturally flowing gait. Stiff joints don't absorb small perturbations well. Shortened steps reduce your base of support timing. Avoidance of challenging movements means your balance system never gets the practice it needs to stay sharp, so it actually atrophies further. The fear doesn't just feel bad, it mechanically makes your walking worse, which increases the actual risk of falling, which increases the fear, which makes the walking worse still. It's a downward spiral that has nothing to do with how strong your legs are or how healthy your inner ear is. Breaking this cycle requires deliberately, gradually re-exposing yourself to movement in safe, supported ways. Ideally with a physical therapist who specializes in balance retraining, in an environment where you can practice the very movements you've started avoiding, with someone there to catch you if needed. Confidence, rebuilt safely, is itself part of the medical treatment. It is not a side issue. It is central to the fix. It is not a cane. A cane can help in the short term, and there's no shame in using one. But a cane alone doesn't address why you're unsteady. It just gives you something to lean on while the underlying problem continues untouched. It is not simply exercise more in some vague general sense, though movement matters enormously as we've covered. The real fix is something called vestibular rehabilitation, combined with multifactorial gait assessment. And almost nobody hears this phrase from the regular doctor because it requires a referral most general practitioners don't automatically think to make. Here's what that actually means in practice. A specialist, usually a physical therapist trained specifically in vestibular and balance disorders, conducts a detailed assessment of all three systems we talked about earlier: vestibular function, vision-related balance contribution, and proprioception. They observe your actual walking pattern, often from multiple angles, sometimes using simple tools to measure sway and step patterns precisely. They check for BPPV. They assess hip and core strength specifically as it relates to gait. They review your medication list with an eye specifically toward balance-affecting drugs, in coordination with your physician. And then, this is the key part, they build a customized program targeting your specific weak links, not a generic balance class that treats everyone the same regardless of what's actually wrong with each individual person. This integrated approach exists. It works. It is covered by many insurance plans, including Medicare, when properly referred and documented. And the overwhelming majority of older adults with gait imbalance complaints never get access to it because the system defaults to a much lower bar, a cane, a generic warning to be careful, and a referral to a balance class that doesn't address their specific underlying cause. If you take only one action from this entire video, take this one. Ask your doctor specifically for a referral to vestibular rehabilitation and a comprehensive gait assessment by name using those exact words. Don't accept a generic answer. Insist on understanding which of your specific systems is the actual problem. While you're pursuing that referral, which can sometimes take weeks to schedule, there are things you can begin doing immediately that are safe for almost everyone and supported by research on fall prevention and balance. Practice the single leg stand near a sturdy countertop, holding on lightly at first, then progressing to just fingertip support, then to no support at all as you improve, working up to 30 seconds per side. This directly trains your proprioceptive and vestibular systems to work together. Walk heel to toe along a hallway, like you're on a balance beam, near a wall you can touch if needed. This forces your brain to actively engage balance correction in a controlled, safe way. Address your vision. Get an updated eye exam if it's been over a year. Make sure any glasses prescription is current, because outdated vision correction directly worsens balance, since vision is one of your 3 core balance systems. Reduce trip hazards at home, loose rugs, poor lighting, cluttered walkways. Not because your home is the cause of your imbalance, but because removing avoidable hazards lowers the stakes while you work on the real underlying issue. Stand up slowly. Sit on the edge of the bed or chair for a few seconds before fully standing, giving your blood pressure time to adjust and reducing the lightheaded, unsteady feeling that often hits in that exact transition moment. And finally, stay moving in general. Walking, even cautiously, even with support, keeps every one of these systems engaged. The worst thing you can do for long-term balance is stop moving out of fear, because as we discussed, inactivity doesn't preserve your balance, it erodes it. None of these replace a proper medical evaluation, but they are safe, evidence-supported starting points you can begin today while you pursue the deeper answer. Let's bring this all the way back to where we started. You haven't thought about how to walk since you were a toddler because your body handled it automatically through a constant, silent agreement between your inner ear, your eyes, and the sensors in your joints and feet. After 70, that agreement starts to break down, not because you're simply getting old, but because specific, often identifiable, often treatable things are happening. Inner ear crystals drifting out of place, medications quietly affecting your balance, hip muscles that have weakened from this use, and fear itself making your gait stiffer and less stable. The real fix isn't the cane, and it isn't the vague instruction to be careful. It's a proper vestibular and gait assessment that identifies exactly which of your systems needs help, followed by a targeted plan to address it. You deserve more than "that happens as we age." You deserve an actual answer. If this video helped you understand what's really happening with your balance, or helped you understand what's happening with someone you love, share it with them today. This is exactly the kind of information that changes whether someone gets the right care or spends years being told to just be careful. Subscribe for more videos like this one. We break down the real medical reasons behind the symptoms seniors are told to just accept, and what can actually be done about them. Stand tall, walk steady, and don't settle for a shrug when you deserve a real answer.